صباح الخير نرجع تاني معلش. We will talk about history, indications, contraindications, equipment, technique, normal pressure waveforms, abnormal hemodynamic findings, and what are the data we can obtain from right heart catheterization. So to start with history, Werner Frostman, he was a surgical student in Germany in 1929. He performed the first right heart catheterization on a human by inserting a 65 centimeter urethral catheter on himself and it was accessing his left antecubital vein. From that time, right heart catheterization evolved until Dr. Swan added a balloon flotation catheter that allows a standard pulmonary catheter to float all around the right-sided chambers with pressure measurements. And Dr. Gans developed the idea of the direct measurements of the cardiac output using the thermodilution technique. And because of the catheter widespread use, the pulmonary artery catheter has now become known as we all know it, the Swan-Ganz catheter. So, what about the indications of right heart catheterization? They are numerous. Some are for diagnosis, and they aid also in therapeutic implications. For diagnosis, they are used in the diagnosis of patients with suspected cardiogenic shock to determine the hemodynamic profile. They are also used, right heart catheterization is used in the evaluation of patients with dyspnea to diagnose or to exclude PH, constrictive pericarditis, restrictive cardiomyopathy, and in some situations when there is a high suspicion of HFpEF, heart failure with preserved ejection fraction. Actually, this is a good standard modality to confirm such a challenging disease. The right heart catheterization is used to determine the vasodilator response to vasodilator therapy in patients with PAH, pulmonary hypertension. It can be used to evaluate the intracardiac left-right shunts to quantify the shunts by the commonly used equation. As we can see, QP divided by QS is equal to the aortic saturation minus mixed venous saturation divided by pulmonary vein saturation minus pulmonary arterial saturation. Right heart catheterization can be used to guide hemodynamics and fluid management in patients with heart failure, with shock or complicated myocardial infarction or early after surgery. And of course, is a modality used for anatomical evaluation of patients with congenital heart disease. Right heart catheterization is used for evaluation of cardiac transplantation to assess eligibility. Surveillance says post-cardiac transplant, post-transplant with new or worsening symptoms suggesting graft rejection. Pre-implantation assessment of the left ventricular assist device, LVAD, and post-implantation optimization of LVAD can be used for endomyocardial biopsy when it's needed in patients with suspected amyloid, sarcoid, myocarditis, eosinophilic, autoimmune myocarditis, and so on. And in some patients with valvular disease, when there is a discrepancy between the clinical and non-invasive data, we can use right heart catheterization to make a diagnosis. Therapeutic indications for right heart catheterization include device closure of atrial ventricular septal defects, PDA MAPCAs, can be used also for transseptal puncture for mitral stenosis and percutaneous mitral commissurotomy, thrombolytic therapy and the percutaneous treatment of acute massive PE when thrombolytic treatment is failing or contraindicated systemically, balloon valvuloplasty for pulmonary stenosis, Rashkind procedure to allow good mixing of blood in patients with TGA. Right-sided access is needed for cardiac pacing in patients with AV block, and sometimes for insertion of IVC filters for VTE when there is a contraindication or failure of therapeutic anticoagulation. How about contraindications? Absolute contraindications include right-sided endocarditis, right-sided tumor, or a thrombus. Relative contraindications include severe coagulopathy or bleeding diathesis. And caution should be exercised in patients with a prior left bundle branch block and in the setting of arrhythmias. This is a catheter used. It's a pulmonary artery flotation catheter. It's a dedicated catheter for thermo dilution technique measurement of cardiac output. So the catheter is around 110 centimeters long, and French sizes vary based on the manufacturer from 5 French to 8 French according to the body size. All catheters, they have a distal yellow port and a proximal blue port, as we see. And the presence of a thermistor allows the third port to the catheter. So step by step for the technique. First, a local anesthetic is given subcutaneously at the access site. Venous access is obtained with or without ultrasound guidance. We can use a needle of 18 gauge or a smaller needle 21 gauge, and the access sites are commonly the femoral or jugular veins, but it can also be the antecubital vein. Appropriately sized sheath is placed in the vein and secured. Then the pulmonary artery catheter is advanced through the sheath into the vein, but the balloon is inflated only after the catheter is advanced for 15 centimeters to avoid inflating it within the access sheath. If the catheter advances easily, then the use of wire cannulation is not really necessary. The catheter will reach the right atrium when advanced to roughly 20 centimeters from the jugular axis or 45 centimeters from the femoral axis. The catheter movement also can be observed by fluoroscopy. Zeroing is a crucial step to allow for adequate pressure measurements, and it involves opening of the air fluid transducer to the air to equilibrate طبعا pressure with the atmospheric pressure, and the air fluid transducer must be at the level of the heart at nearly imaginary plane between the anterior and the posterior chest walls. And here are the different movements we use when we advance the catheter through the right-sided chambers. So there is first counterclockwise rotation to allow advancement of the catheter into the superior vena cava. Here. Okay. And then the catheter is rotated in a clockwise fashion when it's inside the right atrium to allow the tip to pass through the tricuspid valve and be positioned below the right ventricular outflow tract. Then another clockwise rotation will allow the catheter tip to be oriented towards the pulmonary artery, and then the catheter is advanced in the wedge position to measure the pulmonary capillary wedge pressure, and then the balloon is deflated and brought back a few centimeters to allow measurement of the pulmonary artery pressures. And it's important, of course, to take all pressure measurements at end expiration. And then the samples are taken from the distal yellow port for pulmonary artery saturation, which implies mixed venous oxygen saturation. And the arterial saturation has to be obtained separately to determine the cardiac output using the FEC method. That's about the technique. These are the normal pressure waveforms. The right atrial pressure, which is composed of 3 positive spikes and 2 negative spikes we will mention later. And the normal right atrial pressure is around 0 to 8 millimeter mercury. And this is the right ventricular pressure wave 4. The right ventricular systolic pressure is normally between 20 and 30 millimeter mercury, and the diastolic pressure is between 0 and 8 millimeter mercury. And this is the normal pulmonary artery pressure waveform, and the systolic pressure is around 20 to 30, and the diastolic pressure is around 8 to 15 millimeter mercury. And the pulmonary artery wedge pressure, which in its waveform looks similar to the right atrial pressure, and it should be normally less than 12 millimeter mercury. How about the right atrial pressure? It's important to know about the right atrial pressure in particular for some diseases, because it has 3 positive upstrokes and 2 descents. The A wave, it correlates with atrial systole. The X descent, it reflects atrial relaxation. The C wave indicates tricuspid valve closure. The V wave represents passive atrial filling during right ventricular contraction, and the Y descent represents atrial emptying of the tricuspid valve opens in ventricular diastole. As you can see here, this might be a better illustration. The A wave for atrial systole, this the X descent, and the C wave for tricuspid valve closure, the V wave and the Y wave. V wave is for atrial filling, and Y descent is for atrial emptying. And these are abnormal waveforms that can be observed in some disease states. For example, in atrial fibrillation, the A wave is absent. In patients with AV dissociation, such as incomplete AV blocked ventricular tachycardia, AV nodal reentrant tachycardia, there might be a very large A wave, which is called the Canon A wave. In patients with increased ventricular volumes, such as in tricuspid regurgitation, mitral regurgitation, failing hearts, left ventricular or right ventricular systolic or diastolic failure, or in patients even with mitral stenosis or VSDs, the V wave is usually very large, as you can see here. And in constrictive pericarditis, due to the rapid diastolic filling of the ventricle, there is a very rapid X descent, and similarly, there is a very rapid Y descent. In patients with tamponade, there is equalization of diastolic pressures and no sufficient time for adequate diastolic filling of the right ventricle, and therefore there is usually blunted Y descent or even absent. For right ventricular systolic pressures are elevated in patients with pressure overload, such as in PS, PH, pulmonary hypertension, or pulmonary embolism. For RV in diastolic pressures are elevated in patients with cardiomyopathy, constrictive pericarditis, or RV ischemia or infarction. And of course, right ventricular pressures can distinguish between constrictive and restrictive cardiomyopathy. In constrictive pericarditis, there is a known phenomenon of ventricular interdependence. So there is a discordance of right and left ventricular pressure with reduction in the right ventricular systolic pressure when there is an increase in the left ventricular pressure during inspiration and the opposite during expiration. So here during inspiration, the as we can notice, this is a constrictive pericarditis. This is the waveform of the left ventricle, and this is the waveform of the right ventricle. So during inspiration, the inflow of the heart to the left side is decreased, and the opposite occurs during expiration, and these changes are opposed at the level of the right ventricle. Ventricular interdependence. And this is usually absent in patients with restrictive cardiomyopathy. As we can notice here, there is no significant change between inspiration and expiration. What are the hemodynamic data we can obtain from right heart catheterization? Cardiac output measurements, which rely on two principles, either the Fick method or the thermodilution technique. The Fick method, it determines the amount of oxygen carried in the systemic and pulmonary circulation, and accordingly, the blood volume required to carry that amount can be deduced or can be counted. But it depends on hemoglobin levels, arterial oxygen saturation, mixed venous oxygen saturation, and maximal oxygen consumption values. It's limited طبعا. In a direct measurement of oxygen consumption, it requires special devices and is cumbersome. And accordingly, we use an indirect method, which may cause a 25% variability in cardiac output from the direct method, particularly in obese patients when BMI is above 40 kilograms. Thermodilution technique, simply it relies on injecting 10 centimeters of saline into the proximal port of the pulmonary artery catheter. And so this cold blood mixes with the right atrial, mixes with the right atrial blood and causes a drop in temperature, which is measured at the tip of the catheter by the thermistor. Accordingly, cardiac output can be known, but it's inaccurate in patients with low cardiac output, and it can underestimate cardiac output in severe tricuspid or pulmonary regurgitation due to recirculation of the blood, and the opposite occurs in intracardiac shunts such as in VSD or ASD or PDA. Cardiac index, we index the cardiac output for the body surface area, and normally it's above 2.5 liters per minute, and the cardiogenic shock is defined as cardiac index less than 2.2 liters per minute per square meters, and pulmonary capillary wedge pressure should be elevated more than 15 millimeter mercury. Cardiac power index, which is calculated by dividing the product of mean arterial pressure and cardiac output in liters per minute by 451, is calculated in watts, and its importance relies in the setting of cardiogenic shock, when the cardiac power output has a greater correlation with adverse outcomes compared with other parameters such as cardiac index, ejection fraction, pulmonary artery systolic pressure, and mean arterial pressure, and the cutoff number is 0.6 watts. Systemic vascular resistance can be obtained by the calculation of mean arterial pressure minus right atrial pressure multiplied by 80 divided by the cardiac output. It's measured in Wood units or in dynes per second per square meter, centimeters, and normally is around 10 to 20 Wood units. Pulmonary vascular resistance is measured by subtracting the mean pulmonary artery pressure from the pulmonary capillary wedge pressure multiplied by 80 divided by the cardiac output, and is also measured in the same units, and normally it's less than 2 Wood units. Pulmonary artery pulsatility index, which determines the ratio between pulmonary artery pressure and right atrial pressure. So it is the difference between systolic and diastolic pulmonary artery pressure divided by the right atrial pressure, and it has two clinical implications. It can define right ventricular failure with a very high sensitivity and specificity in patients with acute inferior MI, and it can also predict patients expected to have RV failure and consequently require right ventricular hemodynamic device support after placement of LVAD. And the cutoff values, as we can see, is 0.9 and 1.85 respectively. How about our last topic is the complications of right heart catheterization. Ventricular arrhythmias, right bundle branch block, are usually transient, and it resolves once the catheter is removed or the catheter tip is adjusted. Very rarely complete heart block, and usually in the setting of prayer, left bundle branch block, and this may require pacemaker implantation. Air embolism can occur if there is air in the system, in the air fluid filled pressure transducers. The patient presents immediately by acute onset or sudden onset of chest pain, dyspnea, tachypnea, tachycardia, and hypotension. So the patient should be placed in the Trendelenburg position, and high flow oxygen is delivered. In some situations, hyperbaric oxygen therapy is required. Finally, pulmonary artery perforation, which is a very serious complication, yet it's very, very rare, 0.03%. And it's usually due to prolonged balloon inflation at the wedge position, and probably in the setting of prayer, pulmonary hypertension, and systemic anticoagulation. And this usually manifests as sudden dyspnea and cardiogenic shock. Fluoroscopy can help you to know that the tip of the catheter is very distal in the pulmonary artery branches and cause the pulmonary artery perforation. So it's an emergency situation. The patient, the catheter should be left in place, do not remove it. And the balloon should be inflated to minimize pulmonary hemorrhage. The patient should be emergently intubated with a double lumen endotracheal tube. He is put in the lateral decubitus position, and the affected side is on the lower side to protect the unaffected side from ongoing hemorrhage. And probably you should call for emergent surgery or embolization if technically feasible. And thank you. I'm ready for questions. هل في أي شيء غير واضح حضراتكم عايزين تسألوا عليه؟
السلام عليكم.
وعليكم السلام.
محاضرة جميلة يا دكتور، تسلم. أنا كنت عايز أسأل حضرتك عن الثيرابيوتيك انديكيشن للرايت هارت كاسترايزيشن، خصوصا في السيتنج بتاع البلمونري امبوليزم، ريلوتيك ثيرابي، أو الحاجات اللي احنا بنسمع عنها بالكاستر دي. ممكن حضرتك تقول لنا عليها هند؟
مين معايا؟
أنا دكتور عبد المؤمن.
دكتور عبد المنعم ازيك عامل ايه؟
الحمد لله.
هو طبعا كان استاذنا دكتور هشام صلاح ودكتور امير انور كانوا عرضوا موضوع البركتينيوس ميكانيكال فراجمنتيشن والفارماكولوجيكال تريتمنت اوف ماسيف بي اي في سيتنج طبعا اوف هيمودايناميكلي انستيبل بيشنتس، يعني لازم تكون طبعا فيري هاي ريسك، دي اول نقطه، يعني هيمودايناميكلي انستيبل بالديفينيشنز بتاعته. النقطة الثانية إن إحنا عندنا ثيرابيوتيك سيستميك ثرومبوليسيس لازم يكون contraindicated أو failed، فإحنا مضطرين نلجأ إلى يا إما سيرجيكال امبولكتومي يا إما نضطر إلى بيركتينيوس. لازم طبعا يكون عندنا اوبريتور اكسبيرينس ولازم يكون عندنا availability of equipment. هو الحقيقة في محاضرة دكتور أمير كان اتكلم تفصيليا في آخر محاضرة بي إي عن التكنيكال اسبيكتس، لو حضرتك بتسال عنها يا دكتور عبد المنعم، بس هي simply it relies on fragmentation and pharmacological treatment باستخدام برضه thrombolytics ربما لوكالي، يعني بسبيشال بالونز طبعا.
ثانك يو.
اكون اجابتك على السؤال.
شكرا.
دكتور فؤاد، هو انا حمدي نجاح، اخبار حضرتك ايه؟
اهلا وسهلا، ازي حضرتك؟ اتفضل.
بص، هو يعني برزنتيشن قويه قوي وتو ذا بوينت فعلا، بس عايز هو مش سؤال، بس هو يعني حاجه اكسبكتيشن. هو اليوسج بتاع البلمونري كاستر بقت ليميتد قوي اليومين دول، تو ان احنا ما بنشوفهاش كتير يعني. هل تعتقد ان هي في الفيوتشر ممكن تبقى تستخدم اكتر من كده شويه؟
هي الصراحه الانديكيشنز بتاعتها فيري امبورتنت يا دكتور حمدي، particularly في السيتنجز اوف cardiogenic shock، والعيانين اللي هم بيبقى عندهم mechanical complications، والعيانين اللي هم بري هارت ترانسبلانت، والعيانين البري الفاد والبوست الفاد فور هيمودايناميك اسسمنت. فيمكن زي ما حضرتك بتقول كده لما الفاد يوزج عندنا يبدا يزيد اكتر، يمكن الامور تبقى اكثر استخداما. برضو ليها الصراحه طبعا هي الجولد ستاندرد في التريتمنت والدايجنوزز اوف بي اتش، يعني بالمونري هايبرتنشن. ما نقدرش ان احنا نستارت سبيسيفيك تريتمنت سبيسيفيك فازودايليتر ثيرابي من غير رايت هارت كاثيترايزيشن. وكمان هي كلاس 1 ريكومنديشن فور فولو اب، يعني مش بس ان احنا بنستارت تريتمنت بناء عليها، لا وكمان الفولو اب اوف ريسبونس بيعتمد على رايت هارت داتا. فهي الحقيقه ليها استخدامات كتيره قوي، بس يعني نأمل ان هي تبقى more frequently used in the future. ده حقيقي جدا لانها بتتل a lot about hemodynamic tailoring of patients with heart failure و cardiogenic shock اللي بيبقى صعب ان احنا نوين من عليهم الانوتروبس او الفازوبريسرز او غيره. ممكن يقولوا لنا طبعا كتير عن الكاردياك اندكس والكاردياك اوتبوت والبالمونري كابيلاري ويدج بريشر. في بعض الاحيان ممكن تضطر ان انت تدي فلويدز مكان ما انت بتدي فازوبريسرز وهكذا يعني.
بالظبط، شكرا جزيلا، الف شكر.
عفوا دكتور حامد.
ربنا يخليك.
أنا أشكر جميعكم على حسن الاستماع وأرجو أن أنا أكون أفدت ولو بقليل. لو ما حدش عنده أي سؤال فإحنا ممكن ننهي المحاضرة. السلام عليكم.
وعليكم السلام ورحمة